So clearly we're live. Sorry about the technical issues, everybody. We missed a great introduction. We'll do it again, but a little bit briefer. My name is Julia Amstutz. I am one of the clinical research coordinators for the PROMISE study, like Annie, our previous moderator. And joining us today, we are very lucky. We have Dr. Rafat Abonour and Dr. Irene Ghobrial. To give some quick introductions, Dr. Abonour is the Harry and Edith Gladstein Professor of Cancer Research at the Indiana University School of Medicine. Dr. Abonour joined IU in 1995 and has facilitated clinical research at the IU Simon Cancer Center and the IU School of Medicine. Dr. Abonour is also the leader of the Multiple Myeloma Program under the Precision Health Initiative, a holistic and innovative research initiative funded by the IU Challenge Grant. His research under the Precision Health Initiative aims to prevent myeloma and improve treatment for patients, especially those with high-risk disease. He is active with the International Myeloma Foundation and the American Society of Hematology, and his work has been published in Nature Medicine and the New England Journal of Medicine, among others. Dr. Irene Ghobrial is a professor of medicine at the Dana-Farber Cancer Institute, Harvard Medical School, in Boston, Massachusetts, and an associate member of the Broad Institute in Cambridge, Massachusetts. She is the director of the Clinical Investigator Research Program at Dana-Farber, co-director of the Center for Prevention of Progression, CPOP, and the co-leader of the Blood Cancer Research Partnership. Her research focuses on understanding mechanisms of tumor progression from early precursor conditions such as monoclonal gammopathy of undetermined significance, or MGUS, and smoldering disease to symptomatic multiple myeloma, and Waldenstrom's macroglobulinemia. So, brief overview of how this webinar will work. We're going to start by answering some questions, focusing a little bit on research first, and then moving more towards talking about COVID-19. A lot of you submitted questions via email or commenting on our social media pages, and we'll move on to those after that. And then finally, you guys should be able to comment in the chat next to the YouTube video, and we will get to those right at the end. If you need technical assistance, just type in the chat. We have a couple members of the PROMISE study team waiting around, ready to help should you need anything. And finally, a disclaimer. We unfortunately cannot answer extremely specific medical questions in a public forum like this, unfortunately. These are really great questions, and we encourage you to answer or to ask those of your hematologist or oncologist. It's just not something, unfortunately, we can answer due to limitations. So for those of you who don't know or are new to these webinars, I'm going to briefly introduce the PROMISE and PCROWD studies. The PROMISE study is the first research project to broadly screen participants for myeloma precursor conditions. The study is working to stop myeloma before it starts by proactively screening a higher risk population. You can participate if you are between 40 to 75 years old and either identify as being of African descent or have a sibling, parent, or child with myeloma or another precursor condition. To sign up, you just have to go to www.promisestudy.org. The PCROWD study is a tissue banking study designed to collect, process, and store tissue samples from patients with precursor conditions to myeloma. Through the consistent collection of these samples, scientists are better able to track and understand the progression of precursor conditions and overt disease. PCROWD is part of the CPOP Clinic at Dana-Farber, a research initiative focused on understanding the progression and evolution of blood cancers. So, following up on those explanations, Dr. Ghobrial, for those that don't know the PROMISE or PCROWD studies, what inspired you to build such a large prospective cohort study like PROMISE that focuses on screening? And what are you hoping to achieve?
Yeah, of course. Thank you, Julia. And thanks again, Rafat, for being with us today. It's really an exciting webinar, and hopefully this will be educational for everyone who's here with us. What I think inspired me was actually Bob Kyle. Many of you know him. He's the grandfather of myeloma. He's now 95 years old, I think, Rafat. And he's the one who actually coined the name MGUS, monoclonal gammopathy of undetermined significance, because he saw that there were so many people who had the monoclonal protein, who have plasma cells in their bone marrow, who have exactly the same cancer cells that we see in myeloma, yet they don't have symptoms. They're doing well, and they live for so many years doing well. And it was a big discussion, I think, between him and many other leaders at that time, whether you should call it multiple myeloma and should you treat it or not, or should you call it benign gammopathy, and these are people who do not actually have cancer. And he came up with that name, although we know its significance now. He came up with that question of, do not hesitate to follow those patients in the future. Do not hesitate to make sure that we look for precursor conditions that prevent or potentially that can go on to develop myeloma. And indeed, not only he coined the name, he actually developed the first study ever that followed all of those patients in Olmsted County for the last 50 years that told us exactly how those people would progress, that indeed MGUS progresses to myeloma 1% per year in their lifetime, and it goes on and on. So we know that this is not something that stops, and we need to understand why. And he also coined the name smoldering myeloma, which is a name that says it's almost myeloma. It's getting there, and we need to be more careful with it instead of just saying it's very easy and it's just like an MGUS. So this is where the 10% per year. So why did I get excited about this? I think for many years I saw people with multiple myeloma and we treat them immediately and we try to achieve that ultimate cure that we're not getting to it yet. Yet when we see people with smoldering myeloma or even earlier with MGUS, we tell them, watch and wait. Watch until you develop lesions in your bones, until you have anemia, until you have fractures, until you have kidney damage and you fall apart. And it doesn't make any sense. If you talk to any other oncologist who sees any other cancer, like breast cancer, you would never tell a woman with breast cancer, I know that you have this early breast lesion, but don't worry, we'll leave it alone. And we won't treat you until you have metastatic disease everywhere, fractures in your bones, kidney disease and damage there, and then I treat you. It wouldn't make any sense for any other cancer. So why are we doing that for myeloma? And we decided, let's actually tackle it. Let's develop a whole clinic at Dana-Farber called the Clinic for Prevention of Progression, or CPOP, where we only focus on early precursor conditions, MGUS and smoldering, and that's all what we do here at this center. And then we asked the question, well, instead of patients coming all the way to Dana-Farber, although Boston is a beautiful city, it's not what everyone wants to do, especially now with the COVID-19. And you say, well, let's avoid having people come to us. Let's try to get everyone be part of those studies. And we created two sister studies. P-Crowd, or Precursor Crowd, is really crowdsourcing for patients instead of for money. And it's really empowering patients for the first time that you are the one who have the right for research. You as a patient, you have the right to ask the questions with us. And we tell you that wherever you live, nationwide and also internationally, if you have MGUS, if you have smoldering myeloma, if you are in any place, you can be part of this study. You can go online and sign consent. You do not need a physician or anyone else to sign consents with you. And you can submit a sample so that we can get thousands of samples and thousands of clinical data. And then finally, we get the questions answered by doing these large studies. And then PROMISE was developed immediately after by a Stand Up to Cancer grant for $10 million, the Dream Team, asking for the first time in our life, can we screen for myeloma? And I really think that cancer screening saves lives. If you think about it, we screen for breast cancer early, we screen for cervical cancer, yet with a simple blood test, we do not screen for multiple myeloma. And I can tell you it's easier to get a blood test than doing mammography or colonoscopy or any other screening. So why not screen for it? And we thought that especially for African Americans and especially for first-degree relatives, if you have a sister or brother or a son or daughter and you have myeloma, your kids and your first-degree relatives are at a higher risk compared to the general population. So why wouldn't you want to know if you have MGUS? Because knowing early can potentially prevent it. And our true hope in all of this work is, let's someday not actually diagnose patients with myeloma, with active disease. We'll diagnose you early, we will prevent it early, we will know if you need treatment early or not, but truly understand what happens in those patients and can we prevent it or intercept it early. So I'll stop here. I know I talk very fast, but maybe Rafat can tell us about his studies too.
Yes, that was actually my next question. Dr. Abonour actually has two large tissue banking and screening studies. And correct me if I'm wrong, but the cohort study enrolls all of your patients and follows them throughout their lives while collecting saliva, blood, and bone marrow samples. while
Sure.
your MGUS study screens all bariatric surgery patients for MGUS. So how does this information from these studies help you as physicians understand more about myeloma and precursor conditions?
So first of all, I'm very honored to be with you, Irene Ghobrial. She's the smart one in the family. I just go along trying to learn from her. She has done amazing work. I mean, she's every other day there's a paper published by her and her group. So it's an honor to be with you. And I agree with Dr. Ghobrial that I think it's very important that we try to understand MUGUS and try to prevent the development of multiple myeloma, because I think we're getting really good at treating myeloma, but we haven't cured myeloma yet. So I think it will be better to try to prevent myeloma. So one of the things that we are doing here in Indiana is that we know that if you are overweight and you have MUGUS, you have a higher risk chance of developing multiple myeloma compared to non-overweight person. So what we said, let's see what the incidence of MUGUS among those who are going to have bariatric surgery. And then let's see what happened to MUGUS after they have the surgery. So our hypothesis is that by losing the weight, you may actually lose the MUGUS. We do have anecdotal experiences of patients that I've been following over the years for MUGUS, where they lost the weight and they lost the MUGUS. So, I mean, that will be incredible if we can prove that in a large study. So I think the work that Dr. Ghobrial is doing in trying to understand the natural history of MUGUS through her precursor work, and then look at the incidence of MUGUS in the population at risk, because we know if you are African American and have MUGUS, you actually have a higher chance of developing myeloma too. That's based on a large study from the VA system in St. Louis. So I think it makes sense to screen people age 40 to 75 for MUGUS who are African American or have family history. So we excited to contribute to this study, and we also, hopefully our study that we've been able to accrue almost 60 patients on our MUGUS study. So with the goal to accrue 660 patients based on the statistical model to see, how many patients have MUGUS and then follow them after the surgery and see what the impact of weight loss. In addition, I mean, obviously we're doing like everybody else is that, it's better that we understand the sort of the natural history of the disease based on diagnosis, treatment, and outcome, but also combine that with genetic information about the disease, the environment where they live, and also their germline DNA. What makes you, sensitive to certain drugs or how you metabolize drugs. So we collecting information about, patient, what we call germline DNA. So we understand their genetic makeup. We're collecting data on the myeloma cells in the neighborhood where they live in the bone marrow. So our goal is not just the cohort. I think the cohort is the sort of the exercise to learn how to do, data collection electronically, how to put it together, how to enroll patient on this trial, how to collect blood and bone marrow samples and do the analysis quickly and enter it into a big database. But our goal is that for all myeloma patient diagnosed in Indiana, automatically entered on the study. And the more patients we have, the more we're going to learn about the disease, and we can collaborate with Dr. Ghobrial and her colleagues at Dana-Farber by building bigger database. And so the more patients are entered into such database and studied, the better we can treat myeloma. Yeah. So I'm honored to be able to collaborate.
That leads in perfectly to my next question, which is actually to both of you. So how do you see the screening studies and their findings translating from all this awesome research into practice, which is something our patients ask about quite frequently?
Yeah, I think it's a couple of important things. The first thing is, why does it matter for you as a patient? Why would you want to give us a blood sample or your bone marrow biopsy? Why do we ask for this? And you can think of it in a very simple way. If we diagnose you today with MGUS or smoldering myeloma, your first question is, when will I develop myeloma and when will you treat me and how can I prevent this? That's the most important question for you. So for us to have better predictors, better markers that tell you in a more accurate fashion, when will you progress to myeloma, we need markers. We need something that tells us what's going on. And I think of it more like a hurricane is coming in. You can think of the Weather Channel. The guy is very nice on the Weather Channel and tells you there's a hurricane coming, but I have zero accuracy. So I can tell you it may come in the next couple of weeks and it may hit the New England area, maybe, maybe not. I don't know. That's not very accurate. You're not going to be very excited about this because you have no idea if it will hit your area or not. But if that person is much better and the data that he has is more accurate, he would tell you the hurricane is coming on Tuesday in the afternoon and it will hit the Boston area only. That gives us more accuracy. And by having more accuracy, you can live your life in a much more controlled fashion. So think of what we do, all of those markers we try to do are all trying to get you to a one simple thing. When will I progress? And can I prevent that progression? So we use clinical markers, which is what we use right now. 2 grams of protein, 20% plasma cells, or 10% plasma cells, all of those numbers and markers, and we tell you have high risk, you have low risk, you have intermediate risk, and we confuse everything, and we tell you there is the Spanish model and the Mayo model. These are all things that we all try to get to give you in a more accurate fashion what happens. Now, why would the research help us? It's because it gives us more into the biology, and biology always tells us if your disease will progress faster or not. So we just published a couple of papers that are actually from the P-Crowd studies that are actually from your own samples. So thank you everyone who shared those samples with us. The first one was trying to ask, if we look at your cancer cells, can we find new markers in your DNA that can predict if you will progress or not? So even if you have 2 grams protein in your blood, even if you have 10 or 20% plasma cells, but you have bad markers, bad biological markers, your DNA has MAP kinase mutations, MYC amplification, P53 mutation, 17p deletion, things that tell me the cells are growing very fast. They don't want to stop growing. These are markers that tell me you will likely progress to myeloma within the next 2 years. Let's think about treatment early for you. If you didn't have any of those markers, your median time to progression was 7-8 years, even if you had some of the clinical markers that tell you that you're high risk. So I can tell you if you're high risk today by clinical markers, it may not be the perfect predictor whether you should be treated or not. So let's be careful about that, and let's give you more accuracy. The second study that we did was asking the question, well, if the cancer cells are the same, 2 people have smoldering myeloma, 2 people have the same 414 translocation. One progresses in 1 year and the other never progresses. 5 years follow-up, 6 years follow-up, and he didn't progress. Why is that person different other than that he's lucky? And the question is, does he have immune cells that protect the cancer cells from growing? Do they prevent that progression? And this is what we call the immune microenvironment, that your cancer cells don't live alone. They live actually within a neighborhood. And that neighborhood could be a good neighborhood or a bad neighborhood. And if it's a bad neighborhood, by definition, everyone is just acting bad because they're all fighting, and that's the bad immune cells in your system, and it will allow progression much faster. So we started doing something called single cell sequencing, which means we take all your cells, we try to understand each cell, if it's a T cell or a B cell or a cancer cell, and we try to define better whether you have certain markers that predict if you will progress much faster or not. And that can help us in the future develop for you immunotherapy or other therapies that are just very specific for you and not use everything the same way for everyone.
Dr. Abonour, do you have anything to add about research?
No, that was very clear. Thank you.
Okay. So I have one final more research-related question, then we'll move on to another hot topic, COVID. So both the PROMISE study and EMGA study have these specific eligibility characteristics for participants. So you've already kind of explained why you chose these characteristics, but what can you tell us about what makes someone higher risk than someone else for a precursor condition for myeloma? And can you explain how statistical predictions play a role in determining these eligibility criteria?
So I think both of us can answer this question. It's very interesting. We don't have all of the markers that tell us why someone will develop MGUS or not. We know, as Rafat said, germline, which means you're born with something that makes you at high risk. But we don't know that you have very specific genes that 100% tell you will develop myeloma. So you are more susceptible, but something else will increase your chance. And this is what we're trying to know. We're trying to understand, why are you at high risk? Is it because of your African origin? So that's why African Americans have a higher chance. Or is it because there is something that you inherit from your family? That's why we look at first degree relatives. But there are other factors too that we don't know what they are exactly. And then we add to it factors that can increase your progression from this early MGUS to myeloma. And these could be the obesity that we talked about, could be medications like immunosuppressive agents, could be other autoimmune diseases, could be environmental. You live in a place that increases your risk. We know that after 9/11, many people got myeloma. Young people got myeloma in certain areas, insecticides, pesticides. There are so many factors, Agent Orange. All of these, we look at them together with your genomics. And then, of course, age. As we get older, we all get tiny mutations in all of our cells, and some of them will get rid of them because your immune system is good, and others we can't get rid of them. So why is our immune system better in some people versus others, and can we improve on this? So there are so many factors. It's very complex, but we need to dissect it a little bit so that we can tell you if you're at high risk. And I think Rafa's work on obesity and trying to control it and making MGUS go away is such a great idea, right? Because that's a proof of principles that you can change the natural history of MGUS.
Correct. Yeah, I mean, I agree. That's what why you're doing the study, and that's why we, collaborating with you, because we would love to know what really drive MGUS to become myeloma, because not everybody will develop myeloma. So the question is that, is there a, predisposition because your genetic makeup, or is it because of environmental factors, or your immune system is not working well? It would be nice to understand that.
Very, very true. So switching the gears a little bit to COVID-19. As myeloma physicians, how have your experiences with telemedicine been? And as this COVID-19 pandemic evolves and changes, will you encourage patients with myeloma or precursor conditions to continue to use telemedicine services, or to switch back to in-person visits?
Rafat, you go for that one.
Okay. Well, I think, telemedicine can be useful when you're trying to sort of review things that have been, stable for a long time. You can, sort of by talking to the patient, reviewing their blood test, you can understand, what's going on with them. I think it's very important that we still do, what we call physical exam and, human interactions at least periodically. For patients who are undergoing treatment, I think you can't really do that without, seeing the patients, But for, I think, MGUS patients who are in follow-up, smoldering myeloma and follow-up, I think telemedicine can help. I think, I'm so honored that patient drive 4 hours to see me and probably fly 4 hours to see Dr. Ghobrial. But we also, I think, need to be sensitive to that and try to improve the way we take care of patients. And I think, COVID has sort of forced us to start doing telemedicine. And I think it's going to be here and will stay with us for a while. But I don't think will completely replace, I think, the ability, to help diagnose and manage side effects and things like that. So we still need to see the patient on regular basis. I think the question is, do we know exactly, sort of, if you have MGUS, are you at increased risk of getting COVID? And if you get it, how will you get sick? I mean, I think we just don't know yet, and we need to collect more data. As I said, most people experience with COVID is about 3 months. So that's not a vast experience. And, unfortunately, we're getting a lot of publications in the literatures now because you have in the title COVID. And if I submit a paper with the same quality to, New England Journal of Medicine, they will laugh at me because, I mean, it just does not make sense. And I'm sure a lot of myeloma patients were very upset when at the American Association of Cancer Research, there was a paper presented by the group from China saying that if you have hematologic malignancy, and especially myeloma, you're going to actually do poorly. And if you look at the study carefully, there were only 3 myeloma patients. So how can you make a conclusion based on 3 myeloma patients? So I think we need to collect more data. I think there are a lot of effort to look at how myeloma patients do in the COVID area. We need more data. I think with more data, we will be able to know who has at risk, increased risk of doing poorly, or who will do just fine. I mean, I could tell you about the 5 patients I have who are done really well, but that's not science. I mean, I think we need a larger cohort of patients to understand what we can do.
Yeah, I absolutely agree. I would say COVID really opened the door for us to start using telemedicine. And I think there is room for both. There is room for the in-person visits, but there is also room for us to allow patients to be at their own home and still get the care that we have. I'm still trying to figure out if there is an app for a physical exam without being there, a virtual physical exam. There is virtual stethoscope. So I'll get to that, Rafat, in a second. But the whole idea, I think there is a lot of positive in virtual medicine, other than, of course, the physical contact with patients, which we cannot replace. But there are patients that at first I was, worried, are we going to be able to get on the Zoom call together? And then when I got them on the call and we finally got together, it was a wonderful time because it's the whole family. We can even get the daughter who lives in another city also be on the Zoom call. And that wouldn't have happened if she was there in person with me in the office, because you can't get her on the same call at the same time. It was very personable. We were able to do a lot of things together. So I think there is good in virtual calls. And I think avoiding the long trips for many patients and bringing the care to them, to their own home, is something that we would love to offer more and more. And in fact, we thought that especially for patients with MGUS and smoldering, especially for very healthy people who live too far from us, this should be something that we can offer them. It doesn't replace personal time, but maybe every other visit, maybe in a visit when they don't have the time to come to us, we can offer it to them. So I think having that opportunity, having the option not to have to come to us in person, can open the door for better medicine and better care for everyone.
So following up on that, antibody tests for COVID-19 have become a lot more common, and you can now get them a much wider variety of places. But it's been a concern with these tests that you get false positives or incorrect results. And so, Dr. Ghobrial, I was wondering what advice you had for people who are looking to get an antibody test and what people should look out for.
Yeah, I was going to say Rafat should get that question, but fine, I'll start. So I would say we don't know. You're right. There are so many antibody tests, and there are so many of them, and some of them give you IgG or IgM or both, and so on. So I think we should be careful with those and follow the FDA guidelines. We are starting a study, hopefully very soon. We're working on getting IRB approval called Sapphire, and this will be offered to everyone who is on Promise or P-Crowd. So if you are interested to get COVID-19 testing for free through the Sapphire study and get to understand not only if you have an antibody, yes or no, but what is your immune system and what happens to you, we would encourage you. So it will be launched hopefully soon for anyone who's on P-Crowd or who's on Promise or wants to be on Promise or P-Crowd in the future. And the whole idea is we don't even know if you have an antibody, whether you will be immune for long term or not, especially that you have an underlying problem with your immune cells. So plasma cells, whether you have MGUS or smoldering myeloma or active myeloma, are the ones that make immune antibodies. So will you be able to be immune 6 months from now, a year from now? Will you get reinfected? We don't know. So we're asking that question, just like Rafat said. If you don't know the answer, don't ask it in 5 patients, ask it in 5,000 patients. So we are asking the Sapphire study, everyone who wants to enroll, as many as you want, please go on and get tested for it, because it will give you the opportunity to get the antibody test through Quest Diagnostic, but it will also give you the opportunity for us to do immune cell sequencing on your blood and try to understand whether you have an immune cell system that will prevent having COVID-19 in problems in the future.
Yeah, I just want to echo the fact that if you test positive for antibodies, does not give you a carte blanche to live your life, and go in the pool with 500 people. So you want to be really careful, do the social distancing, the mask, and washing your hands until we understand what it means to have antibodies.
So that means your bike ride is gone, huh?
Well, it's going to be almost virtual this year.
Just for everyone to know, you should know how much Rafat bike. You should actually tell everyone because many of your own fans are on this call right now, right?
They know. No, but I mean, we've been doing for 15 years, and this will be 16 years miles for myeloma. So started by running. I used to run 50 miles, and now we just bike, 2 days in a row, 100, 120 miles each day. So it's been a good journey. We have great people
I
supporting
can
us.
do the first
Basically,
10 with you.
yeah. She's actually a marathoner, Dr. Ghobrial. She ran Boston several times.
Just once, but yeah, I can't bike.
It's enough.
As you guys mentioned, you guys are both no strangers to these kind of grueling long-term events, whether it's Boston Marathon or the Pan Mass Challenge for Dr. Ghobrial or Dr. Abonour is the founder of it. The bike ride is over 150 miles around Indiana, correct?
Yeah, I mean, each day about 100 miles. We do 2 days. Sometimes we've done 3 days. We rode one time from St. Louis to Indianapolis.
Wow.
I mean, one.
What keeps you guys going back to these events, considering they're not particularly easy physical feats?
Yeah.
I guess it's a challenge. Huh?
Your devotion to these patients, clearly. One final COVID question to Dr. Abonour, a little Midwestern focus. So there's been some clear variety in how different areas of the country have experienced the pandemic and how quickly or slowly they're reopening. So for all your patients in the Midwest and similar regions that are opening up even more and more every single day, do you have any advice for those with precursor conditions on how to handle this reopening of the country?
Yeah, I mean, I wish I have a very, an answer based on sound medicine, science. But I think my gut feeling is that there are simple facts that we can use to sort of prevent getting, exposed to COVID. I mean, I think the problem is that, the young, the healthy carriers, that you're not aware of them. And, I would say that, until we understand the way this virus is spread, we know that, close contact for a long period of time, indoor, makes a difference. So, I mean, I think that's why I think it's very important to follow the guideline in terms of social distancing. If you want to go out to eat outside. Don't eat inside. Keep washing your hands. I think that's really very important. And I think the mask. I think is going to be with us for a while. I mean, I don't like the mask. I actually hate the mask in the clinic because it's just amazing when you see somebody's face. If you don't see the whole face, it's just you're not really connecting with that patient. So I hate the mask. But I think a lot of people have said that the mask is very helpful, when you are in close contact with people, especially if that's going to last, several, a long time. So I think my advice, social distancing, hand washing as much as you can. I don't want you to live in a bubble. I don't want you to stay home, but I think you need to be, when you're outdoor, try to spend more time outside. If you're inside, like a mall or something, be very careful. Try to avoid the indoor stuff as much as you can. Do you agree, Dr. Gopia?
Yeah, absolutely. Again, it's a very hard time, and
Yeah.
especially for patients who are a little bit, their immune system is not completely normal, and that's the problem. You don't know your risk, you don't know what's going on, and you don't know if you get infected, will you be the one who goes to the hospital or will be asymptomatic? And I think the more we get information, the more we will be powered or empowered to be able to give you more information and to tell you what to do. So we're lucky that we're 3 months and 4 months into it, not the first few weeks. We already know more about it. And hopefully we will get some treatment sometime soon. But in the meantime, being careful and avoiding exposure is the right thing to do.
Thank you guys for that good advice. Hopefully everyone takes it into account. So we're going to switch gears for one final time and answer some patient-submitted questions. The first one, and either of you can answer. What are some signs that precursor patients display that indicate they have moved from the watch and wait stage to the begin statement stage? Begin treatment, rather.
Rafat, maybe you can take it first.
Since I try to understand the question, so what are the signs?
I think people are curious if there are signs and symptoms that indicate that they should be moved out of this watch and wait bubble into let's begin more aggressive treatment or any treatment phase.
Yeah. I mean, so obviously, when you move from MUGAS to smoldering myeloma, then to symptomatic multiple myeloma, you know, this is why I think we need Dr. Ghobrial work, because I think will help us understand, for example, I have, patient I've been following for smoldering myeloma. They have not met the criteria for what we call high risk smoldering myeloma, where they need maybe to be on clinical trials or treated. And then all of a sudden, and next visit, they have symptomatic myeloma. Can we predict who are these patients? I don't think we have yet the tools, but from a standard of care, I guess if you have many plasma cells in the bone marrow more than 60%, or your free light chain ratio more than 100, or you have one of the CRAB criteria, high calcium, kidney failure, anemia, or bone disease, then you treat the patients. I think the question is, can we get the patients before they have a big fracture in their spine and they're very symptomatic from that? I think that's when we really need to learn how to predict that better. And that's what, I love your example of the hurricanes, when is it going to hit, because I think that's the most important thing. You don't want people to live in a shelter for 6 years and then, when the hurricane hits, they are out there, being exposed to it. So we need better science, and that's why we need larger studies like, the PROMISE study. But I think now we just do it based on clinical criteria. I mean, I don't know if you agree with that, Dr. Ghobrial.
Yeah, absolutely. I mean, that's the biggest dilemma we have, right? Can we predict before you have signs? Can we predict before you have the bone pain or anemia or fatigue or any of those symptoms, so that we can find it before you have that feeling and that problem from it? And that's why we tell you, come and see us every 6 months or every 3 months or once a year, and don't stop the follow-up. I've seen some patients who say, well, I've had MGUS for 10 years, so I will stop seeing you. And the answer is no. Come, let's talk about life. Let's talk about the kids and grandkids and where you traveled lately. But don't stop seeing us, because we don't want to miss that time when you actually do develop the symptoms, when your kidney function worsens or your light chains goes up, because they do, even after 10 years, after 15 years. That's a natural progression. So don't miss those opportunities to get that checkup.
Someone specifically asked about decreased bone density or osteopenia, and does that indicate any relation to MGUS results, or what is the correlation between that and MGUS?
So Rafat, that's your area, bone biology.
So actually, we both have worked with my colleague who's here at Indiana University, Dr. David Rudman, who is the international expert on bone disease and multiple myeloma. So obviously, we know that plasma cells, malignant plasma cells, can increase bone destruction, and by stimulating the cells that destroy bone. So the question always comes, which is really difficult to answer, is that if you have MUGAS and you have osteopenia or osteoporosis, is that related to the plasma cell disorder, or is that related to other factors? So I think that's why you need a very good clinician that can really sort of try to dissect that. You want to make sure you don't have any other reason to explain the osteopenia and osteoporosis. But we tend to be, trying to be more aggressive in treating osteopenia and osteoporosis in the setting of monoclonal gammopathy, because I think it can influence, the quality of life, But it does require close analysis of the patient to see if those few plasma cells in the bone marrow, the 3-5% abnormal plasma cells, are they culprit that's stimulating the cells that destroy bone or not? So it takes a good clinician, I think, to answer that.
Yeah, and it always surprised me to see that MGUS is not that benign. So when people say, oh, MGUS, there's nothing, it's completely asymptomatic, yet if you look at it more carefully, there is bone loss. There are studies that show that indeed there's osteopenia even with MGUS. Even when we looked at immune cells at MGUS stage, the immune cells are not normal. They've already started to change and they're in your bone marrow. So that means that maybe responding to vaccines is different. Maybe also bone loss is because of those changes. So again, I think even at MGUS, you have to think about what can I do to protect my bone health, and should we be doing something. There were studies a long time ago, and we still use them, where we treated patients for bone loss versus nothing, and it prevented bone problems when you develop myeloma. So in patients with smoldering myeloma, not with MGUS, we are telling them to consider something called bisphosphonates or bone-forming drugs to help prevent bone loss or to prevent lesions. But again, we need more studies, we need more information as we go on.
Yeah.
We had another question about kind of more active based, like what can you do to help prevent these, or not prevent, but just slow your progression? And so two questions that tie into each other. Someone asked, what would you tell someone that is beginning treatment, the top 2 to 3 things they could do within their control to help minimize the impact of MM? And someone else asked if there was any documented correlation between enhanced physical activity and slowing down the progression of MM.
It's a good question.
So I can help maybe with the second question, and then I have to understand the first one when they started treatment. I think exercise and de-stressing and decreasing inflammation in general is such an important factor. And we're trying to understand now the link between aging, inflammation, immune system, and myeloma progression. And there is definitely a link between all of them. And we know that exercise and having less stress is sort of reversing your aging, your normal aging. So it takes away some of that inflammation environment, and it takes away a little bit of that immune change. We need to prove that. And in fact, we are working on a few studies. Catherine Marinek, who's one of our wonderful new colleagues who's working with us at Dana-Farber and the School of Public Health, is starting studies like intermittent starvation, or like exercise and de-stressing, or metformin, which is a drug that actually changes your metabolism early on. So all of these studies are for the early MGUS. Can we change your natural history before you get into smoldering myeloma? So if you are exercising, even if you're walking, if you're de-stressing, if you're doing yoga, these are all great things because it can help decrease that inflammation and improve your immune system and potentially change your progression. We don't know for sure, but it doesn't hurt.
Yeah, and that's equally, I think, adding the diet, improving the quality of the food we eat to make it more anti-inflammatory is very important, So I think, a lot of people said sugar does feed cancer, and in an indirect way, probably it does, So if you're eating a lot of simple carbohydrate, I think you're not serving yourself well, because not really maybe stimulating the cancer cells to grow, but also generating an inflammatory state that stimulates cancer cells indirectly.
And there goes my banana bread.
What?
I was just saying, and there goes my banana bread that I had today in the morning.
Well, at least it has banana in it. No, yeah. So I guess some of my patients were talking about the antibodies. I think, the antibodies, IgG and IgM is the one that, yes, the one you have, but, the question is, what is it reacting with, your normal IgG and IgM? Is it reacting to the COVID virus protein? We don't know. I mean, I think that's what we do in the testing.
So we've also had another live question about there was a report about the effectiveness of Dexamethasone for COVID-19 patients with acute respiratory symptoms, and patients wanted to know your thoughts on that.
Yeah. It was a big paper in the New York Times today. No, just you want to answer it, Irene?
No, go for it, Rafat.
No, I mean, I think the problem with COVID is really the inflammation that caused. I mean, so the question is that, when the patient has these pulmonary symptoms related to COVID, I mean, it's like any other infection. It's cytokines mediated, which means these inflammatory proteins your body is producing. And I think by, sort of suppressing them, you may actually make the patients feel better, So, sometimes when we have an asthmatic patient and they have a flare, we sort of think about, maybe they have an infection, so we treat them with antibiotics, but also we treat them with steroids. And they actually have a better outcome when we combine the steroids like dexamethasone or methylprednisone or prednisone with antibiotics. So I think maybe that's, I think, what these people were talking about. I have not seen the actual study, but that's my, sort of my interpretation of that headline. Okay.
So we have a couple of more logistical questions. So Dr. Abonour, for your MGUS bariatric study, what BMI is more considered to be at risk for MGUS? And could you talk more about your qualities for inclusion in that study?
Yeah, so I mean, what we said in our criteria in the study is BMI above 30. But we are dependent on the surgeon. I mean, because they are the one who making the decision whether the patient go to surgery or not. But the minimum BMI that we want for our study is 30. We know that from the St. Louis large study of 7,000 some patients, that the higher the BMI, the hazard ratio, so the risk of developing myeloma is higher. So I don't know what the rationale for that, but so BMI in our study more than 30. Observations suggest that the higher the BMI, the more maybe likely you're going to develop myeloma, because obesity is an inflammatory state. So there's a lot of inflammation taking place, and inflammation produce these protein that stimulate plasma cells to grow, and if they start growing, I think that's when you may get into trouble.
Makes sense. Dr. Ghobrial, so given that COVID-19 is not going away anytime soon, what advice or how would you recommend that someone go safely get their blood drawn so that they can participate in the PROMISE study reopenings? And the PROMISE study is actually reopening on June 22nd, which is great news. But I'm sure it presents some problems for people that are worried about getting their blood drawn safely.
Yeah, it's a great question. Should I go out? Should I get my blood drawn? And I think most patients now are starting to be comfortable to go to a place where they know that we have the precautions. We have the PPEs there. We have all of the information available. So in fact, going to a hospital or going to a lab where they're drawing the blood may actually be a very safe place because they have the PPEs, they're all wearing the masks, and maybe easier to go to than going to your local supermarket where you're not sure what they're doing exactly there. So I would say, again, if you're uncomfortable, we do have the option of sending phlebotomists to your home, and that would be an option. But most of the patients, as long as they're comfortable and they feel that they know the place that they're going to, and most of our patients are going to Quest Diagnostics. And again, those labs are very well informed and they have all the precautions. So we would love to see patients feeling comfortable to go get their blood drawn.
And then slightly related to switching gears a little bit, but keeping on this train of maintenance therapy. A patient asked, they have participated in clinical trials in the past, and they're expecting to see their labs rise after they go off that active treatment. And they're curious about kind of what's next or what's out there in terms of options for smoldering multiple myeloma maintenance therapy in the near future.
Yeah, that's a tough question. So we know that we offer clinical trials, and I really still don't think that we should be offering standard of care therapy yet for smoldering myeloma, because there are so many questions that we don't have an answer to. So although I early on started by saying, it doesn't make sense that we see a patient with smoldering myeloma yet we don't treat you, I come back and tell you, but be careful, don't just go on standard of care. Don't just go on Revlimid or Revlimid and Dex alone. Although it has benefit, we don't know a lot of things. We don't know who should get that. What is the benefit for high-risk smoldering myeloma with a bad cytogenetic abnormality like 414 or 17p? Would that actually harm you more because we're killing some of the cells but not all of the cells? Would you be better off getting something better, like 3 drugs or 4 drugs in the future rather than getting only 2 drugs? So there are lots of questions, and I would encourage people who have smoldering myeloma, if you are interested in treatment get treated on a clinical trial. There are so many trials available. Some of them are for lower risk cytogenetics, some of them are for higher risk, but definitely think of a clinical trial, and we have those all available on clinicaltrials.gov. The second question will be, so I got treated, and sorry, that's my dog here beside me. I got treated on a trial and yet my numbers are going up. What do I do? Am I going to progress to active myeloma? So this is what we call biochemical progression, meaning your numbers are going up, but you haven't met criteria yet for active myeloma, which are, as Dr. Abonour said, the CRAB criteria: high calcium, anemia, bone lesions, and so on, plus 60% plasma cells and light chain ratio. What do I do with that? And we have some data from the two prior studies, the ECOG study from Dr. Lonial and the Spanish study from Dr. Mariví Mateos, and they both followed very carefully the people who had this biochemical progression. Some patients actually, they sort of stabilize back again into smoldering and they stay stable for many, many years. Some people do progress rapidly, and we need more studies to understand this. I think offering another trial for that patient, especially if you were on a single agent DARA or something simple that didn't give you really benefit, if you're thinking of another trial and it allows you to go on that trial, that's perfectly fine. If you're at such a high risk that you're almost myeloma, talk to your doctor about being treated for active myeloma. It's the standard of care thing that if you're almost myeloma and you may need the treatment, we would offer it. So, but we have to be careful. You have to talk to your doctor. This is why you need a myeloma expert who can help you make that decision so that we can help you without waiting too long, but at the same time not over treating you. And this is what's important. Rafat?
No, I agree with you. I mean, I think there are several trials, and we actually have the Ascent trial that I'm, fan of. So we had several patients. The first patient on the trial was my patient, and he finished 2 years of treatment last month, and he's in complete remission, MRD negative, minimal residual disease negative. So it's really great to see that he's been MRD negative for over a year. So that's, I think it's, we're learning more about how to treat smoldering myeloma, and I think clinical trials are very, very important.
One last question to kind of wrap up the whole webinar, actually about treatment, but connecting it to COVID risks. So a bunch of patients have asked us if they've had chemo and a bone marrow transplant within the last 5 years. Would they be considered people with a higher risk of COVID-19 complications?
So, I mean, it's like, saying all myeloma patients are the same. I mean, it really depends on, what's going on with you, what treatment you're on, in terms of maintenance, what are your lymphocyte counts? Have you had your immunization? What have you done with your immunizations? I would say that, in general, I think, and also your age. I mean, are you in the high risk age? Do you have a comorbidity that makes you at high risk of getting sick when you get COVID? I mean, if you, a young myeloma patient is, your immune system is fine, you don't have any comorbidity, I think your risk is going to be like anybody else. So, and I get these questions asked a lot, and I think, I think your immune system is fine, and I think you're going to do fine, but why test the water? Why should we, so try to practice, common sense, and, the most important thing is you keep your hand washed, and, and don't be with large crowds, until we figure it out, but I don't want people to just live in a bubble and live at home, but I also, let's not test the immune system. That I think in general is going to be fine, but every patient is different, and they need to discuss it with their doctors. What is my risk? We have to add all these things: the age, the comorbidity, the lymphocyte counts. What are you being treated with, and then figure out your risk. And then everything we do is risk and benefit, and we just have to see what we're comfortable with.
Yeah, absolutely. I would say probably patients who have had transplant and had to stay at home and be in the bubble for a while are probably the best people who know how to deal with COVID-19 and the hand washing and wearing the mask and all of that. And, you know, these are the ones who have been prepared to be in a COVID-19 situation. So I think just making sure that you're aware of the risks and taking care of yourself is the most important thing.
Yeah.
Thank you guys for giving all that advice. It has been such a pleasure to have you with us today, especially to go virtually to the Midwest. I'm a Hoosier, so it's been great to have Dr. Abonour of my home state on as well. So is there anything else you guys want to plug and tell people about? If you're interested, you should definitely go to www.promisestudy.org. Sign up or tell your friends, but that's my personal opinion.
Yeah, I mean, I hope everybody that in Indiana will really buy into trying to get on the study. Not because she's gonna, you know, Dr. Ghobrial is gonna buy me dinner, but I think, but I really think it's important because we are going to screen more patients in Indiana in high risk area, high risk population, and I think this is sort of the gateway to understand how, you know, Hoosiers will, you know, sort of deal with screening for the pre-myeloma condition, what the attitude, what their enthusiasm. And I think if you guys show us that you know, by, you know, 1,000 of you who go on the study, I think we will know that Hoosiers really care. So I encourage everybody who knows somebody who's age 40 to 75, African American descent, or with family member with myeloma to go on PROMISE study. Please do that.
Thank you, Rafat. We really appreciate it. And thank you again, everyone who joined us today. And thank you, Julia, for doing a wonderful job, and the whole team who's part of the PROMISE study team who are just doing an impressive job behind the scenes. It was really an honor, and we had a great time. So hopefully you guys enjoyed it too.
I'm going to end the broadcast. Thank you guys all again, and thanks for watching, everyone.
All right. Thanks again, Rafat. I owe you a dinner.
Thank you.